Hi, everyone. I am Jenifer Talley. I'm the Assistant Director here at the Center for Optimal Living. I'm here with my colleague, Molly Bobek.
Hi, welcome everybody.
And so what we're going to do today is talk about Molly's work here with us and how she approaches working with families and couples using an integrative harm reduction framework. So we might have some technical issues. Our internet's been kind of cutting on and off, so just bear with us and stay tuned if you lose us for a second. But I'm hoping that for those of you that are watching us, if you want to chime in, add some comments, we can certainly try to answer your questions towards the end of our time together. So we'll have about 30 minutes. And so I wanted to start just by kind of setting the frame by talking a little bit about what harm reduction is, what we mean when we say integrative harm reduction psychotherapy, and then its application in working with couples and families. And then Molly will describe the approach that we're using here at the center. And then, like I said, we'll open it up for questions and feedback. We'd love to hear from you all if you're watching us now. So when people ask, what is harm reduction? And I think there's a lot of misconceptions about what that actually means. And the way that I think about harm reduction, it's simple. It's really principles and strategies aimed at reducing the risks associated with drug and alcohol use. And I think of it as a way to extend the reach of traditional treatment models that might have a focus just on abstinence. And so we think about harm reduction as extending the reach of traditional treatment where there is no requirement to maintain abstinence, at a starting point or even as an end goal of treatment. Abstinence certainly is a part of the harm reduction umbrella in that we work with clients who are pursuing a variety of positive change goals that can include risk reduction, moderation, and abstinence as well. And the reality is that most of the people that come to treatment with us here and in other settings, when they first become concerned about the relationship to substances or alcohol, they might not yet be ready, committed, willing, or able to maintain abstinence. And so what we're doing is we're allowing room for people to have ambivalence, to not quite yet be ready to commit to this goal of abstinence. And so what we do here at the Center for Optimal Living is we work under this model that's called integrative harm reduction psychotherapy. It was developed by Dr. Andrew Tatarsky, who is the founder and director of our center here. And so integrative harm reduction psychotherapy, the way to think about that model is that harm reduction principles frame how we set up the therapy. And first and foremost, we're meeting our clients where they are. And so the starting point for treatment is really this collaborative alliance around whatever it is that they're most concerned about addressing in treatment. And so the other really, I think, critical piece of the work that we do here at the center is that we focus on the therapeutic relationship. And so we establish trust, safety, and we really want to empower and encourage our clients to set really realistic goals for themselves to then meet their goals in ways that make sense, that are reasonable, and we don't come in with this kind of a priori mandate about abstinence being essential for treatment. And so what we do find over time is that many clients do realize that the safest option for them is abstinence, but that's just not exactly where the starting point is in treatment. And so the other part of the model that I think is important to point out too is that we're focusing on the whole person. And so we adopt this biopsychosocial lens where we take into account the important kind of meanings that are associated with use, the multiple functions, the needs that are being met through substance use, and then the context under which a person is engaging in their substance use behavior. So we really do take this holistic, whole person approach to the work that we do, and then we integrate other models into the work, including psychoanalysis, relational psychodynamic therapy, cognitive behavioral therapy, mindfulness, DBT strategies, and we treat, again, this whole person using skills and strategies that are really personalized and tailored to the unique individual that we're treating. And then really being sensitive to what's happening in the therapeutic process, the alliance, and then offering skills, strategies. And one of the things that we often use with our clients is mindfulness. And we'll often teach them skills either one-on-one in individual therapy, or they can join our groups to learn these very useful skills to learn how to be with oneself in a way that's more compassionate, that's more about noticing what's happening and what's unfolding minute to minute. And then making choices about how to proceed that's more in line with one's goals and values. And so, we view that collaboration is inherently empowering. And so we do view the work that we do as very collaborative and very personally tailored to the people that we work with. So I don't know if people have any questions now about what I've just said about harm reduction psychotherapy. Happy to pause for a second, or we can just segue into Molly talking about how, she uses her work here and integrates harm reduction into the work with families and couples. So I'll let you say a little bit about your background, a little bit about what you're doing here at the center.
Sure, thanks. So I'm really happy to be engaging in this conversation about the way that IHRP and family therapy are uniquely positioned to serve clients and their spouses, their loved ones, and their families. So my background is that my training is in work with couples and families. I also worked in research and continue to work in research and then in teaching family and couples therapy. So I guess I'll talk a little bit about what I feel like are the natural overlaps between IHRP, the principles you just talked about, and the spirit and execution of family therapy, as I believe it to be effective. Mm-hmm. I think the main place of real synthesis is in this idea of collaboration. I think the stance of the therapist in family therapy is one of transparency and collaboration. We are not experts that move in and dictate to families or in relationships how things should be run, whereas we're experts in facilitating conversations between loved ones, between family members, between people that are connected to one another, towards these goals of creating clarity in all relationships and closeness in relationships that people choose. But even in that goal of clarity in everything and closeness in which people choose, the emphasis is on the goals, the ideas, the meaning making that the clients, that the families have. I think I'll also share that, the way that I work and the way that family therapy, sort of at its core, works so well with IHRP is this notion of sort of dismantling either or thinking towards elevating both and thinking, understanding how two seemingly like at odds ideas could both be true at the same time. I think we see this all the time in our work with couples and families, someone that's sort of deeply committed to a relationship and loving, and yet is making choices that it causes negative affect that's really difficult for their loved one. How could both of those things be true at the same time? I think that's a really common example that we run into. And I think our challenge is to dismantle the idea that those two things can't be true at the same time, to elevate both and thinking rather than either or. And also to make room for multiple perspectives. That's also a real hallmark of family therapy, and I think a hallmark of the IHRP approach. That moving away from an expert stance and more to one of collaboration and validation and support, and inviting people to think about what's effective and what's working for them, rather than what we might think would be the best choices for them to make.
Right. We often view the client as the expert in his or her experience, and our job is really to kind of guide them through this positive change process.
Absolutely. And I think the other thing that I feel like is a really powerful synergy, I know that in some of the IHRP principles, there's a talk about how the urge to use becomes the vehicle for attending to what this person needs to shift for their positive goals. We say in couples and family therapy that the problem, sort of presenting problem, in this case often substance use, becomes the vehicle for working on the relationship. Substance use may be the reason why people end up coming here for couples and family therapy. But some of the ways that we explore around that is how can this be the moment to have things be different in a way that is better for everyone in the family.
So kind of looking at the substance use as a symbol, it contains information, there's meaning there, and it's something to kind of try to explore and kind of get underneath.
Yes.
And to borrow Andrew's term, unwrapping the urge, kind of looking at the use and what is it telling us? What's the information that's there? And then from your lens, looking at how it's impacting relationships with loved ones.
Yeah. And I think, again, sort of both things are true. We understand that this is telling us something about the relationships, the system, and also at the same time, understanding, a big question that I often ask couples and families is, so if we weren't talking about the substance use, what would we be talking about? So it's both. It's understanding it as having tremendous sort of relational meaning, but also knowing that there's a lot more happening in this family and in this couple historically and in the present moment. What if we were able to put substance use on a shelf for a moment? What else might we be able to understand about what's working in this system or in this family, this couple, and what's really challenging right now?
That's a great way to put it. So one of the things that we sometimes hear about is this notion of interventions. I don't know if you want to speak to that, because I think that there's this belief kind of in our culture that, you know, interventions is maybe one of the only ways to kind of motivate someone to then get into treatment.
Yeah. I think that we hear about that a lot. You know, I think it's something that some people will also say has been sort of effective for them. I think where I'm coming from, and I think where we collectively are coming from, is a tremendous belief in sort of the power of relationships for change. Just a real fundamental knowledge that people get better in the context of relationships. Sometimes that is in the context of a relationship with a therapist, often it is, or in a group, a therapeutic group. I think the challenge that comes up for me around sort of a traditional sort of what we sometimes call in the field sort of a Johnson-style intervention, in which the person's decision to go to treatment or to commit to abstinence is in the balance with the relationship. I think the challenge that I see, that I experience with that, is that if we take that relationship off the table, because of where that person is at in that moment in terms of their change goals, what future opportunities for healing and connection are we sort of cutting off? I also think that you know, the way that people end up making decisions to change is often in the context of just, we know from behaviorally, right, from the opportunity for positive reinforcement, and what might exist to, rather than withdrawal of support, what might, you know, more support look like. I mean, that's not to say, you know, I think that folks that are connected to loved ones that are misusing substances, that's always something that should continue. That's not what I'm meaning to say. I think one of the things we actually do talk a lot about is helping family members collectively thinking about what are we doing that's working, that's effective, and what are we doing that's not working, that's ineffective. So by saying, like, by supporting connections between people rather than putting withdrawal of support on the table, that happens at the same time as thinking about what ways you connected that are actually against your interests, against your loved one's interests, perhaps sort of feeding this problem in a way that doesn't feel good to you.
Right, and I wonder if this might be a good time for us also to acknowledge the important work that Dr. Robert Myers has done in developing the CRAFT model, in that, you know, it's a community, you know, reinforcement and family training model. So I don't know if you want to speak a little bit about, you know, Bob Myers' model, how you think about CRAFT, its kind of relationship to what we're doing here at the center.
Yeah, thanks. I think that CRAFT is something that has a tremendous evidence base that we've had the opportunity to be exposed to in a meaningful way, which I think was really wonderful. I think, you know, the goals of CRAFT are really to help the loved ones take care of themselves and to support the person misusing substances to beginning treatment. Also, CRAFT has been shown to have evidence base for decrease in substance misuse as well. I think that what's really so helpful about CRAFT is, as you mentioned, is a little bit of sort of what I was talking about helping people really understand their relationship to what the problem is without pathology. I think CRAFT is really housed with a really sound behavioral approach about understanding in what ways might the loved one be sort of in the CRAFT vernacular, sort of the concerned significant other, and what might they be sort of unintentionally supporting the problem continuing, and what way can they be more effective. And I think it's tremendously powerful. I think in particular, this piece that I talk a lot about with parents and with spouses is this notion about what would it mean to step away from preventing my loved one from experiencing natural consequences from their own behavior.
Right. And I see that there's a comment here. So one of the comments is, can you accept people into treatment while they're still using and do this work? I wonder what you make of that question.
Yeah, I'll share that, you know, I feel like one of the strengths of couple and family therapy, which again, I feel like is a really great analog with IHRP, is that we have a frame that people are living together, that people are engaging with one another. And so by that, you know, there isn't a particularly high threshold for whether or not this person is sort of like ready for treatment, whether or not this is appropriate. What I would say about that is that if people are, again, sort of in relationship with one another, then this is an opportunity to attend to whatever is happening. I think the task of family therapy and couples therapy certainly is to explore the meaning that both people or that all people in the family are making of whatever's happening at the current moment. Maybe that's that they're still using, maybe that they're not using, and what's come from that. So I would say that particularly with working with couples and families, we definitely will begin to work with people and continue the work to people, whether they're using or not. And I know that, I don't know if you want to speak to the sort of individual piece, but I know it's the same.
Exactly, right. And the majority of our clients do come in still at this point where they might feel a lot of ambivalence and conflict around the decision to either reduce their use or stop. And I think that what we're known for and what I think we do really well here is that we open up a space where people can feel safe and supported in exploring what's going on around their use. What are the pros and cons? What's the ambivalence? What's that tension about? And how can we move towards just setting very small positive change goals that could just be starting to notice urges and cravings, beginning to do some urge surfing to really get at what's underneath and what's underlying the use. And then we can start to think about, what do we want to do? What kind of changes do we want to set up? But the reality is that we do often work with people that are still very, very ambivalent and they're not yet ready to stop using. And of course, we're going to accept them and work with them and provide this very safe, compassionate space where they can then be empowered to make decisions about whether or not they want to make changes to their use.
I think that a big part of what the couples and family therapy looks like is normalizing some of that ambivalence.
Exactly.
I think just like sort of like there's a dominant cultural narrative that speaks to a goal of abstinence like being a prerequisite for treatment or being a prerequisite for kind of satisfaction in one's life if one has encountered some challenges with substance use. And so I think a big part of what I end up doing here with couples and families is normalizing that ambivalence and also making room for the CSOs to sort of increase their tolerance of it. Because when we don't have space for those multiple perspectives, when we're reduced to sort of either or thinking, it's not optimal for people's goals, and it's not optimal for relationships either, because it means that there's constraints, that there isn't room for authenticity.
Right, and just to really make that clear, that we do see substance use as being on this continuum of risk, severity, and even with different substances. A person might be using alcohol in a way that's not problematic, might be using another substance like cocaine in a way that's very problematic and could be dangerous. And so, we really do get really curious about the use and invite our clients to be curious about the meaning and the function of their use. And then we think through what to do about it together. And then I've got another question that sometimes comes up in our work as well is, what do you do when, there's a loved one in the family system who is continuing to use alcohol, for instance, and that person may not have an issue with alcohol, but then the person who's the identified patient who is in treatment with us might be working on an abstinence plan. So how do we negotiate that tension maybe in a family system where one person is continuing to use while the other person is in an abstinence place?
Yeah, I think that's really common. I think the good news and the bad news is that there aren't any rules. And so I guess what it comes down to is my work is sort of creating a space for the family or the couple to sort of figure that out for themselves. And I think it can look lots of different ways. For one, I think common way that often looks is that the person that is working towards reducing their alcohol use feels uncomfortable with asking their loved one to do anything different, because it sort of feels like that's reinforcing of kind of maybe some roles that have been put in place about like sort of I'm the sick one and you're healthy and I don't want to impinge on that, rather than asking for what they might need to have sort of a home environment or a going out environment or a restaurant environment, vacation environment feel healthy and supportive to them. And so I think often what happens is to open up the space a little bit for both people to share what they might need. I mean, the other thing, the converse of that, of course, is that the person that may feel like they don't have this challenge with alcohol, and then feel like their loved ones' challenges now end up like overly influencing their own life. And again, it's just about opening up the space for that. I think that what we want to be supportive of is that the couple or the family identifying a plan that's both supportive of everyone's sort of like healthy goals and of the relationship. and not pushing people into silos or into rigid roles.
Mm-hmm. That's a great way to put it. So the other thing that we've talked about too here at the center is this notion of a spectrum of family engagement.
Yeah.
If you want to speak a little bit to that too.
Yeah. I think it's something that, this idea of that spectrum or that continuum came out of sort of our experience working with couples and families. And I think we'll talk about a little bit.
Oh, we're back.
We're back.
All right, so we'll go back. I'll ask the question again in case we
Okay.
lost it. But one of the things that we often talk about here is this notion of spectrum of family engagements. I thought you could speak to that a little bit.
Yeah, I think we've talked about this as a way that we sort of observed our work, as a way to describe what we do, and also I think as a way to invite people sort of participate. And I would say sort of on one end of the spectrum is sort of like family psychoeducation about our approach, about substance use, about harm reduction strategies, about safety strategies, sort of education for CSOs. That's sort of on one end of the spectrum. I think as we move along that continuum, when we think about more involvement, one way of being involved is really thinking about psychoeducation about the particulars of someone's treatment. That might mean sort of a therapist being in touch with a parent about their perceptions of how things are going. Obviously informed by a sort of a decision dialogue with the client themselves about what feels important to share, and that's a sort of a collaborative process of identifying. I think as we move sort of further on the spectrum, there's also this idea of sort of coaching, where a therapist can be in a position of offering kind of tips or guidelines or support to the parent or the spouse or the sibling or the adult child, whatever it is, for how to connect in this moment of the person being in treatment or not in treatment. And to sort of the furthest end of the spectrum, which I think is the place where I find the most effectiveness and am biased towards, is real relational work in the context of someone being in treatment. And that end of the spectrum, the client is the relationship. The client is not the person using substances. The client has all these connections between people, and we work on attending to those connections and healing ruptures or in creating clarity, and attending to having everybody in the family think about what they might want to be different and what they could do themselves to have things be different.
Right. So here's another comment here. So how do you help people figure it out for themselves when they have not been able to figure it out for themselves? Haven't we often heard that their best thinking got them here, and now they need to listen to someone else?
I think it's a good question, and I think sort of speaks to, again, maybe an either or that sort of needs to be dismantled, which is that if we're in a position of collaboration and transparency and the client as the experts of their own experience, that doesn't mean that we are agnostic about safety. That doesn't mean that we don't have wisdom about what's most likely to be effective. That also doesn't mean that we don't share, again, from that transparently about what we think might be the most helpful next step for someone to take. And in fact, I think after a real collaborative assessment, we may be directive in sharing with clients what we think should happen. So I think the both ends that I'm thinking about in this thing is that as collaborative and transparent and honoring expertise of the client and feeling like we do have a lot of resources at our disposal as professionals. That both things are true. We don't sacrifice our wisdom and experience as professionals to the service of elevating the client as expert.
That's a good way to put it. I wonder if you want to say a little bit about, family versus couples work, what feels different, what's the same?
I think the main thing that's different is, this notion of sort of hierarchy. Like a lot of my training in family therapy comes from sort of thinking about structural family therapy and also Bowenian family therapy that's really thinking about the connections between people and thinking about intergenerational work. And I think that when we're often thinking about families, it's really thinking about how to best help and support parents being parents and kids being kids. And that can look lots of different ways. That can mean kids being in moments where they're aiming to sort of get to a higher level of responsibility than they've had before. It can be about supporting parents and kind of getting back some of their own wisdom and sort of sense of feeling authority, and I mean that sort of in a good way, towards their young people. And so I think the biggest piece is that notion of hierarchy that exists with sort of families and couples. I mean, with families rather than couples. And then I think, besides that, I think a lot is sort of really similar in terms of exploring premises that exist in a couple's relationship. What is everyone's expectations when they were coming into this? Exploring premises in a family relationship. What are the expectations around how my parent is going to be there for me? What are my expectations about what my young adult child would be behaving or relating to me? Exploring history is relevant in both. Sort of the history of family of origin for both. I think understanding cycles of interaction is the same. I think, I think they're pretty close.
Mm-hmm. All right. And then the other thing that I wanted to make sure that we highlight is that we've recently launched a new family and adolescent assessment model, which I think is really unique. And I think it's something that we're going to continue to do. So I thought you could speak a little bit about that. I know you've done several of those here recently.
Yeah, I think I'm reminded even of that question about sort of like what we have to offer. I think when we think about our way of wanting to do this family and young adult assessment model or adolescent assessment model, I'm reminded of that notion that we do have something to offer families that come in or clients that come in that they're coming in with a challenge, with a problem. So I think the model is really designed to capture the experiences of everyone in a family. And the way we do that is by involving sort of myself as the family therapist and then an individual therapist. And we spend time all together as a system, the family, the individual therapist and the family therapist, getting everyone's ideas, trying to make a beginning frame to hold at multiple perspectives. And then we also want to allow for that private assessment. So within the context of the same assessment period, the same appointment, the young person can have the opportunity to speak with an individual therapist and talk about more their perspective of what's challenging. And then the family therapist has the time to talk more with the parents about their perceptions of things. Like that can be an opportunity to talk more about what's been really challenging for them, what's hard for them, their sort of history that often is there of sort of feeling inadequate as parents, or the tremendous pain that comes from having a child or a young adult that is struggling in a meaningful way. And then before folks leave, we want to really share with them our feedback, our ideas about what could be helpful next steps. We want to share with them what we see as a sort of synthesis across those groups, and work together really collaboratively. It invites the family to be collaborative as we even model for them how to relate to one another, how to hold different ideas and present different ideas at the same time.
So kind of fleshing out what the initial treatment plan might look like and the different people that are going to be involved in the process.
Yeah.
I wanted to see if there were any more questions. So here's another comment. So Johan Hari says the opposite of addiction is connection. It sounds like you're placing a big emphasis on seeing healing relational connections as a central part of what heals. Can you speak to that?
I love that quote. It's really something that the converse of that, right, is that thinking that this problem is one of isolation.
Right, that we have to detach, we have to step away.
Yeah, I think that, I'll speak to, it definitely just resonates with me. You're raising it because I think, it's a part, it's sort of inherent in a little bit what we're talking about. I think the thing I'll add is that I think that it is about clarity as well in that connection, because I think sometimes we see both with couples and families, there's this idea couples in family therapy, oh my gosh, that's about all of us being super tight and kumbaya, and what if I'm not ready to do that for anybody in the family, not just the person that's coming to treatment that's identifying as having a substance use problem. And so I'll say that, so it's both about fostering connection and closeness when people choose, but also sort of bringing clarity, so I think that that's one of the things we talk a lot about as well, is the opportunities to create it here. Maybe sometimes it can look like having more intact boundaries. So that's that's what I'll just add to that, because I think sort of absolutely, it's thinking about the power in relationships to be healing. And perhaps healing looks like less connection at times. But I think we want to do that in a supportive and way that reflects the history of in the relationship.
Great. Thank you. It's good comment. Yeah, these have been good questions. So before we sign off, because it's about 30 minutes in, I wanted to see if there were any more questions, comments. We're also happy to take your feedback in about other Facebook Live events that we might do in the future. Also encourage people to check out our website, which is centerforoptimalliving.com. If you want to subscribe to our mailing list, there is a little tab at the bottom where you can just enter your email and subscribe. And then if you don't already like our Facebook page, you can like our Facebook page, and you'll be made aware of different activities and events that we have going on. I don't see any more questions. I think that we might sign off for now, and I just really want to thank Molly for her time, for her expertise. It's been lovely getting to know you and working with you here.
Yeah, it's really been great to be here and to be in this ongoing conversation about the synthesis between IHRP and family therapy.
So stay tuned. We'll do this again very soon, probably sometime in mid-October, and we'll see you all then.